So this is a 63 years old male patient presented with chest discomfort, and there was a minor changes in the ECG, and LV function was fairly normal. So this is the angio, and you can see there's a CTO in the LAD. This is the iliocaudal view, and in this ariocaudal view we can see there's a CTO with the taper tip. JCTO score probably is a 2. So this is the cranial view, and you can see the collaterals. There's a bridging collaterals as LED is filling from the RCA, PDA, and this was the RCA, and you can see the from RCA only LED is getting filled, and there's a bridging collaterals, and in mid RCA you can see there's a more than 90% lesion and ostial PLV. So in this cranial view, we can see the mid RCA and ostial PLV, and you can see the LED, distal LED is getting filled from the RCA collaterals. This is a distal LED, retrograde filling. So as the patient was stable and LV function was normal, my plan was to do the provisional stenting to this bifurcation at the PLV PDA, because there's an ostial lesion at the PLV. So right from RCA to PLV, I'm going to put a provisional stent, and then we'll do the pot and all. And then one stent will put in the mid RCA where the lesion is, and then we'll try the CTO of the LAD. Once I will secure the supply, distal LED is getting supply from this collaterals from the RCA, so I will secure the RCA, and then I'll try to do the LED CTO with anti-grid wire escalation technique and HDR technique, and if time allows and contrast allows, then we will try to do the retrograde also. So already the patient's creatinine is 1.5. So with the right femoral approach with this catheter JR, this is the BMW PTCA wire. One wire I made a knuckled wire and placed into the PDA so that it won't injure, and one wire in the PLV, and then I pre-dilated the lesion in the PLV, then placed a stent of 2.5 into 20 from the RCA to PLV, as this is a provisional stenting, and then we'll do the pot. So one wire was in the PDA because all the LED is getting filled from the PDA, so my concern was it should not get closed, so I was very careful. And then this was a stent deployment at 12 atmospheric pressure. It was nominal. This is a picture after the stenting, after the angioplasty in the RCA PLV. There's no pinching of the PDA, and then we did the pot. Then I removed the gelled wire from the PDA and then recrossed the wire, and then wanted to stent the mid RCA, and this was a 3 into 32 stent and deployed in the mid RCA. So it was at 12 atmospheric pressure, it was nominal. So this is a picture after the mid RCA stenting, and you can see due to bend, you can see there is some haziness, but in cranial view it has gone. So this was a final shot of the RCA. So already patient's creatinine wave 1.5, and it was, I think, 150 ml of contrast we used during the RCA angioplasty. So this is now the LAD, which was a CTO. So I started with the Vesper wire, and you can see wire is buckling, not crossing the lesion, not crossing the proximal cap. Then we went ahead with the balloon support to cross the proximal cap of the CTO segment, but balloon has not worked. So we took a microcatheter. It was a fine cross microcatheter, and this is the wire, the filter XT wire, Somehow I tried to cross it, but it wasn't. So somehow some 1 or 2 millimeter wire I crossed, I guess, and then I put the microcatheter over there, and I decided to try the hydrodynamic recanalization technique, and this is the HDR technique. I put the microcatheter at the proximal cap, where I think I was in LAD only, not subintimal, and then I pushed the 1 ml of contrast, and you can see there is a recanalization you can see in the LED. This is a HDR technique. So by this time I thought I have crossed, and this micro channel in the CTO segment has given me the way with this HDR technique, but it was not. And once again I tried with the wire, but wire was not crossing even after seeing the recanalization. So by this time we used almost about 300 of contrast, and creatinine was 1.5, so I decided to stop the procedure. It was almost 2 hours, so we'll plan this procedure. So this was a final scene. You can see there is a segment of almost 20 to 30 mm of CTO segment with hard proximal cap, and you can see the retrograde filling of LAD. So it was a attempted CTO of LAD, and we will plan it later. So this was angioplasty to the RCA and CTO LAD.